All right. Good morning, everyone. Welcome to Musculoskeletal Institute Grand Rounds this morning. Excited about today's program. We will give our CME color of the day to be teal in honor of yesterday, which was the 80th anniversary of the hospital. Charlotte Memorial Hospital opened 80 years ago yesterday. We have a great series of talks today. I'm going to ask Dr. Moorman to give a quick welcome and then turn things over to Dr. Scannell.
Thanks, Josh. Want to welcome our panelists and really appreciate your time to spend with our next generation and let them know what the end of the tunnel looks like. Having been involved in resident education for 30 years, it's something that I know what the product needs to look like, and really excited about the folks we're going to hear from today and the light that you'll shine on our folks here. One thing that I would also let you all know as alums, and it's always exciting to talk to alums, is that we were just walking, Jeff Niesel and Josh Pat and I were walking the new space of our new headquarters at Mercy. So once the COVID cloud clears, we're very excited to welcome you all back and see our new digs here in Charlotte that I think you'll be excited about. But thank you for being with us today. And Brian is going to introduce you all. So Brian, take it away.
Thanks, Steve. So Dr. Pat and I had been talking. We had an open date sort of a little bit at a last minute, and we kind of were discussing what we thought would be something nice to add on. This is not something we've done before, but definitely something I think both of us look forward to doing in the future. We wanted to have an alumni forum to bring some of our previous residents back, really as more of kind of an advice or giving session to our current residents. So I've invited, and Dr. Pat and I have invited 5 residents back to join us. These are graduates from 2011, 2014, 17, and 18. We have some outstanding graduates, and I look forward to hearing from some others as well. 2 of the speakers this morning are from Charlotte currently, and 3 are those that are gone elsewhere. So I look forward very much to allowing you guys to hear from these 5 individuals. Dr. Pieri was a graduate in 2018, Dr. Bates in 2014, Dr. Haynes in 17, Dr. Ade in 2018, and then Dr. Loeffler in 2011. So thank you guys for all joining us on such short notice. I think we gave them about 3-4 weeks, maybe max, to kind of get prepared for this. We're going to save all questions and everything for the end. So we have 5 talks from each of them total this morning, and we're going to start with Dr. Pieri. So I'll have Dr. Pieri pull up her slides. So Dr. Pieri, as I said earlier, was a graduate of our program in 2018. Following residency, she went directly into practice. So she is in a military service currently, and is currently practicing in San Antonio at the Military Medical Center there and Brooke Army Medical Center in Fort Sam Houston, Texas. So I'd like to thank Dr. Pieri. She will be heading on to a trauma fellowship eventually. She's applying this year to fellowship, so she can also certainly discuss that with some of our current PGY4s that are going through a similar process. So Dr. Pieri, one other comment I'll make. I told her, she asked me how would she know if she made it, and I told her if we invite her back as a visiting professor. So Dr. Pieri, you've made it, and thank you for joining us.
Thank you guys for having me. I really appreciate it. It's quite the honor. This morning I'm going to be talking about transitioning from residency to practice. And this is a tough topic because I know a lot of people go to fellowship first, whereas I went straight through. But I think that there's a lot of correlates that we can derive from both experiences that are going to be pretty honest no matter where you're coming from or where you're starting. I think the mistake that people think is that training and education stops when you leave residency or fellowship. And that has been the biggest, not really surprise, but really the biggest investment on my part, has been in continuing my own education and practice. And I think there's a lot of ways to do that. And so we'll talk about some of those today. The difference between training and residency is that, or fellowship, is that you have someone overseeing your education. So yes, we consider ourselves adult learners, but there's still there are requirements that you have to meet. There's someone monitoring your progress. And at the end, you get a certificate of completion. Someone seems to think that you're done. But in practice, for the first time, you're in charge and you're the one that's ultimately responsible. You're responsible for your patients and for your education and ultimately for your own growth as a surgeon. And I think that that's a really heavy burden, but it's also something that makes this just a really wonderful job. So jumping into practice, I'm going to divide this quick talk into just three separate things: growing your craft, recognizing opportunities, and managing complications, which I think are three hallmarks of the first years in practice. And I'm starting my third year right now. So the first section is going to be on growing your craft. And I think that real emphasis here is focusing on the fundamentals. What were you trained to do in residency and trained to do in fellowship? And what do you do well? And you'll notice that kind of this idea of what do you do well involves both the skills that you've developed, but it also involves the confidence that you have. And sometimes it takes a little time and some practice to get confident in those skills, and that's okay too. So I think in the beginning of practice, my recommendation would be really focused on the fundamentals and on kind of the skills that you have in the direction that you're going. And one way to do that is to prepare. And I think that CMC trains us to preoperatively plan really well. And I actually still write down written preoperative plans for most of my cases. And I'm in my third year of practice now. And a lot of it is because, you know, the more complicated cases you're doing, the more maybe you have to plan. But we also took a lot for granted in residency in terms of having staff and people around us who are really comfortable with the procedures that we're doing, who are very familiar, who are familiar to you, and who can help bail you out. And that may not be the case in practice. So I'd encourage you guys to, in residency, look at how your attendings plan and really take that to heart, because that's going to be really important when you get into practice. And the other thing is focusing on indications or on clinic. As a senior resident, I thought that, you know, I should be spending every single available second in the OR. But it turns out that the beginning of surgery starts in clinic, and that's when you indicate your patient and learn to talk to them about surgery. So I really encourage you guys to spend time there and focus on the exam maneuvers or the history things that are causing your attendings to recommend surgery for a patient, and then listen to how they talk to patients about expectations, because that prepares the patient and also prepares you. It helps you both know that you're headed in the same direction. Another big thing is identifying sources of knowledge and skills. And I'd encourage you to differentiate between mentors and your partners there may be times where those overlap, but to cultivate both of your relationships. I think more of my mentors is people who I can ask for advice, whereas my partners are people who can be physically available to be in the operating room if I need help during a tough case. And I would encourage you guys to ask your partners or ask the people around you both for advice and for help when you need it. I've learned so many valuable skills from my partners in the last 2 years, and they've helped me out of some tough situations as well. It's better to be able to plan to have someone in the OR with you than to be, you know, calling out when you're stuck. So again, that's part of planning, but it's also part of cultivating relationships. And I think that's really important. Asking for help is not a weakness. It just shows that you have enough insight and that you care about your patient enough to make plans for that ahead of time. And finally, be critical of your x-rays and your outcomes. Even when patients don't have a complication, there's probably something you could have done better from a surgery or from a case, or to make that x-ray look better, or maybe to help the patient out down the road. And I would encourage you to think about every surgery as an opportunity for growth and to pick up on those little details, because that will make you a better surgeon. So addressing complications. You know, you've heard the phrase, if you don't have enough complication, or if you don't have any complications, you're either not doing enough surgery or you're not acknowledging them. And I think that's really true. The key with complications is to identify them, don't stick your head in the sand, to disclose them to the patient and have an honest discussion, and to not abandon the patient. And when I had my first complication, I called Dr. Gant, and she was incredibly helpful, kind of walking me through both the emotional turmoil of having brought someone to surgery and then had a complication, and also kind of the pathway to making it right and making it better. So I'd encourage you to find these mentors who can help you through that process, because it can be really tough and it really takes a toll on you, but it can also lead to really valuable relationships with your patients, and it can teach you a lot about the process of being a good surgeon as well. So this is one of my early Trail of Tears x-rays from practice. When I fixed an intra-articular distal humerus fracture, she fell, pulled off her electrical osteotomy, and then it was just frustration from there on out. So, you know, at the end of the day, several months later, the patient and I have a great relationship. You know, we've kind of limited, she's in her 70s, limited her expectations with her arm and kind of got through it together. But it was a lot of tough lessons to learn. And I just encourage you to be really critical of yourself and make it a learning opportunity for you, but don't abandon the patient, stick with them the whole time. And the last thing is to recognize opportunities. You know, some of my mentors and the people I respect most kind of had this idea of don't say no when you're first starting out, and be willing to take on tough cases, be willing to take that extra call, and just understand that your partners will be grateful. They'll see you as a member of the team. You're getting more opportunities. You're probably getting more patients for your practice. But sometimes it's tough. And I realized that the flip side of that is that you also have to set boundaries for yourself. And those are personal boundaries and professional boundaries. Sometimes it's okay to say, no, that's not a surgery I do, or that's not something I do well. And sometimes you have to say, I have other priorities right now. And those may be personal priorities too. And it may be a focus on other professional things. So a little bit of that is kind of understanding yourself and where you want to take your practice, but it's okay to be honest with people around you. The second thing is to recognize precocious or unexpected opportunities. And sometimes these comes from your mentors, and sometimes they come from your partners, and sometimes it's just luck. For me, for example, I was able to kind of jump into a role as the surgical directorship for a rehab institute here that really focuses on limb salvage and amputation. And that's just phenomenally changed my practice. It's changed the patients I operate on, and I absolutely love this job. So, you know, that was something that I didn't expect to happen. But I was kind of willing to take a jump and a leap of faith. And I really appreciated my mentors pushing me in that direction. And so that's helped me grow a lot as a surgeon. And the last thing, again, is to cultivate those mentor relationships, because these are people that are going to help you the whole way through. And it's okay to have mentors for practice and for professional things and for personal things as well. You don't have to have a one-size-fits-all mentor. But I'd encourage you to really cultivate those relationships and make them last, because the people at CMC really care about your development and how things are going with you as well. So as we go through practice, we kind of apply this skill plus confidence, and it allows us to expand our comfort zone. So ask yourself, what are you trained to do? What do you do well? And then how confidently can you apply those skills? And this is going to allow you to expand your comfort zone over time. And this just makes it a really productive practice, makes you happier, helps avoid burnout. And ultimately, I think, you know, when the surgeon is happy and confident, then that can lead to it being a really positive relationship for patients too. Thank you.
Thanks, Dr. Peary. I really appreciate it. Lots of great pearls there, I think. You know, asking for help is not a weakness. I love that. You know, it's one of the advantages, I think, to being in the practice that I'm currently in, is I have some great partners that I can reach out to, whether they're pediatric or non-pediatric, to be able to get their input on things. So thank you. We'll take some questions for Dr. Peary and others at the end, but thank you, Sarah. I really appreciate it. Next up is Dr. Bates. Michael Bates is currently here at Ortho Carolina as adult reconstructive surgeon. He was a graduate in 2014 from our CMC program, and then went on to fellowship at HSS for adult recon. Dr. Bates is also now the newly appointed co-chair of the Diversity and Inclusion Committee at Ortho Carolina. So he has many roles and tasks within OC already, after being here for just a number of years. So Dr. Bates, take it away.
All right, good morning. Let me know if everyone can see these slides. I'll get a slideshow started. All right, can everyone see that first slide?
Yeah.
No.
Mike, if you're having issues, we can
Yeah, maybe.
we can skip ahead, and I'm happy if you want to email me your talk, I can try to pull it up.
Sure. Yeah, let's do that.
All right. Well, we're going to move on. Dr. Haynes, if you're ready, I'm going to have you come on. Dr. Haynes was a graduate in 2017. As part of her residency, she also did a year-long research fellowship. She went on to a hip and knee replacement fellowship at Rush, and is currently at Hershey, Pennsylvania, and the Department of Orthopedics at Penn State Hershey. Dr. Haynes, thank you for joining us. And she's going to be talking this morning on how to make the most of your fellowship. I think you're still muted, Nicole.
Does that work?
Perfect.
Okay, and you guys can see my slides?
Yes, we can.
Perfect. Good morning, everyone. I agree with Dr. Pieri. This is a huge honor for me to be able to come back and talk to you about my experience in fellowship and kind of things that I learned. A lot of this piggybacks quite well with what Dr. Pieri talked about in terms of starting practice. But these were some of the highlights and things that I really look back on as beneficial things that I gained from my fellowship and how you can exploit those when you're in fellowship. So this is my background. Dr. Scannell mentioned some of this. I'm currently an adult reconstruction surgeon at Penn State, working with residents in a tertiary care center as well as taking trauma call. So the first thing I will tell you, and one of the most important things that I learned at CMC as well as in fellowship, is to take notes. You will see many different approaches to different things. You will have many different people teaching you the way that they do things. It will be different than what you did in residency. So I think it's very important during fellowship to write things down. Once you're in practice, you can refer to those notes. Dr. Sporer, who's a hip surgeon where I did my fellowship, and I did an ETO early on in practice, and I had a long drive after, so I dictated how we did our ETO. I still can remember dictating that, and then when I'm in the OR now, I can walk myself through that. So I encourage you to take notes, to keep those notes, whether it's via taking pictures, whether it's dictating your notes. Anything you can do to document how things are done will make your life easier when you go forward. The other thing I would say is this is your time. So it's your opportunity to be a complete learner at this point in time. Once you go into practice, there are a lot of other things that pull you in different directions that aren't necessarily patient care or education based for yourself. So I encourage you to go to as many different courses as you can, learn as many different techniques as you can, learn how to expand your toolbox leading up to going into practice. The next thing that I would echo is learn how to plan for cases. And we get a lot of this in residency at CMC, and I had a really good background for this, but specific to joints, I really learned how my thought process was going to work, both in the OR as well as preoperatively. So it's important to learn what your mentor's indications are for specific surgeries. It's important to understand how they strategically plan for surgeries. It's also important to understand what the goals and expectations of surgery are and how to set those and match those with your patient's goals. The other thing is you need to progress through the day and you need to know when you're done. So executing those plans is something that's really good to reflect on while you're in fellowship. This is what we intended to do. Were we able to do that? And how did we move through the process? And then looking at patient outcomes, you know, how did different aspects of the case affect patient outcomes? So just learning all of those things in fellowship is very important. You, again, want to have a big toolbox when you leave fellowship. And I think that's the true benefit of fellowship from a learning standpoint. The other thing I would encourage you to do is to spend more time listening than talking. One of my mentors in fellowship said we have 2 eyes and 1 mouth, so use them appropriately and according to their distribution. And I think that's super important. I think when choosing a fellowship, picking a place that has a good balance of autonomy as well as teaching and mentorship is important. You don't want to go to fellowship and basically start practice. You want to go to learn from people. This again goes with building your toolbox. I would encourage you to be experimental and sample all that you can. When you start practice, people will ask you, what do you want to use? How do you do this? How do you do that? If you haven't had, you know, if you haven't had exposure to different ways of doing things or using different instruments, that can be a little bit daunting. So try different systems, figure out which one works best for you, what works best in your hands. That takes some of the guesswork out of starting practice initially. The other thing, again, is in terms of learning how to do things and how to efficiently get through your day, I would encourage you to not recreate the wheel. When you're at fellowship, request copies of all your mentors' protocols. You know, how do they do their pain management protocols? What do they use for preoperative optimization? What's on their preference card? What is the name of a particular retractor and what's the number for that retractor? Because people call retractors different things. How did they market themselves? Everything like that is important. And if you have those resources when you get to practice and you're setting yourself up, it makes that process more smoother. I would also encourage you to discuss the business of medicine. We have a great education at CMC in looking at the business of medicine, and I felt I came out well prepared to start practice. But I think you can learn quite a bit from how your fellowship mentors also operate their business. Clinic management becomes super important. How do they set up their schedule, and how do they feel that that makes them successful? How do they provide a great patient experience? Where I did fellowship, Rich Berger is very focused on patient experience and marketing. He does a really great job teaching some of the ways that he does things. The other thing is how are you going to manage the operating room? You are the team leader in the operating room, and as residents, you're not necessarily put in that role as often as your attendings are. So look to your attendings and fellowship as well to learn how they manage the operating room. You want to build a team, and seeing how that's done efficiently is a really good benefit of fellowship. I would also encourage you to learn from the mistakes of others in fellowship. This is a patient who is a skydiver who had a partial knee arthroplasty done. When we removed the implant, the cement had interdigitated underneath the polyethylene, and this led to a whole slew of problems for this patient with cement debris, and she ultimately went on to revision total knee arthroplasty. This really highlighted the point to me about cement preparation when putting in a partial knee, and it's a mistake that I, fortunately have not made in the operating room, and felt like I learned from this case. This is another case. As a metal on metal hip. One of my mentors said, if you can't get a stem out, work at it for 45 minutes, and at that point convert to an extended trochanteric osteotomy. This patient had a metal on metal hip on the left with a chronic infection. Unfortunately, instead of an ETO, they presented with this fractured trochanter. So potentially progressing to an ETO sooner would have been beneficial in this case. The other thing I would encourage you to do is be part of as many big cases as possible, and figure out how you get to the end point. So this is a patient with a loose acetabulum, but she's got many complexities to her case. It's a monoblock stem. She has deficient abductors. So this is a case where a CT scan was obtained preoperatively, and we were able to plan preoperatively how to do this. But the thought process of this case was really extensive, and it goes along with the planning aspects of things. Ultimately, I think that people in fellowship are some of the best. I encourage you to spend time with your co-fellows, operate with your co-fellows, build a support network, and keep in contact. This is a text chain from my co-fellows yesterday. So we still all frequently text and ask each other questions. And finally, your attendings and mentors are also people, and they're also wonderful. These are a couple of pictures on the left of Chicago, and Wayne Paprosky is the guy in the blue hat, and he takes you out on a boat ride when you do fellowship there. He's also very available for all questions and still somebody that I can reach out to. The picture on the right is a picture of the Lipizan horses in Chicago, and below that is a message I recently sent to Aaron Rosenberg as I was reviewing one of his papers for my boards. And he still is in contact and a great resource for me. So I encourage you to build those relationships within the hospital and outside of the hospital. And enjoy the year overall. That's all that I have.
Thanks, Dr. Haynes. I can't echo enough. The relationship piece is such a big part. You know, similar, I had 3 other co-fellows with me, and I think we have a daily text chain, and there's x-rays that are sent around and cases and opinions. So it's nice having those immediate people available with our current technology. So thank you. I think we're going to see, it looks like Dr. Bates is up and running now. So we'll let him take over the screen and take it away, Dr. Bates. We'll have you take it off mute though.
Good morning. So hopefully we're doing a little bit better with the slides this go around. So happy to be back and happy to be giving this talk about how the residency prepared me for practice. There are a few things that I was considering discussing when we were coming up with this topic, and there are many ways that the residency does prepare me for practice, but these are 3 of the bigger ones that, in reflection, I think have made this transition a lot easier. This is my 5th year in practice since graduating the residency in 2014. And of course, I did a fellowship up in New York after I finished up the residency. So I'm going to talk about composure, collegiality, and handling complications. And notably, a lot of the themes from the first 2 talks you're going to see in this talk as well, which I think really reflects how critical some of these topics will be for you. So when we talk about composure, we all have been down in the trauma bays and major when you're being called to DIAG or PZD, when you're PGY 2 and 3. And I think those first 2 years of your residency really teach you how to handle an incredible volume of trauma, complex patients. And it really sets you up for success in those first years of practice. I think the things that challenge you may be a bit different in your first few years of practice. It could be a really busy clinic and you're running 45 minutes behind and you have to still remain very composed and take care of the patients. Myself, I did start off my practice at a level 1 trauma center outside of Charlotte, and that was without the aid of orthopedic residents. So I can tell you, having that experience and dealing with junior call really set me up for success because, again, I was back in the emergency department in the middle of the night taking care of complex patients. You have to prioritize and you have to be efficient. But one thing you learn pretty quickly during your residencies, you also have to save a few seconds to show empathy for a person. It's quite possible that if, as a PGY3 resident, you can run down a PZD, reduce a pediatric distal radius fracture in 10 minutes, have your note done in 5 minutes, and be on to the next consult within 15 minutes. But it's a little bit different when you have a parent that's sitting in the corner who's very emotional to see their child injured. And doing little small things like making eye contact or, pausing for a second when you're speaking to them can really go a long way to show empathy. And you'll use those same skills even when you're running behind in clinic. And you have 3 lights blinking and you're trying to get to the next room, but you don't want a patient to feel like you're rushing. So those things that you learned for these first 2 years of the residency are going to really help you throughout your career. Lastly, those tips and tricks that you learn in the emergency department, how to move efficiently, how to get a person as quickly as possible from the ED to the OR, those tips and tricks will continue to stay with you. Of course, you're going to be in a different facility, but most of the principles translate across different facilities that you're going to practice in. Collegiality. I think this is a big one, and to be honest, you've really already started working on this now in your residency. You're going to have moments where your co-residents are going to need to switch a call weekend with you or switch a grand rounds presentation or something like that. And it's important now that you learn that this is not the end of such things. This is going to be an ongoing thing throughout your career. The only difference is that you're going to be in much longer term relationships. So it's important that you're a good partner to your partners and vice versa. It can really make the difference in being in a satisfying, work relationship versus one where you're always stressed and having a difficult time balancing your work and personal lives. There's a bit of a transition as well when you're working with other doctors who are not necessarily orthopedic surgeons, let's say medical colleagues like CHG or the emergency department. In residency, it tends to be a bit more of an adversarial relationship. In practice, you tend to realize that you have to build those relationships because you're going to be working together for years. And in my experience, more times than not, those other docs, ED docs, the CHG service, those other teams will really be helping you take better care of your patients. So I feel like it's a little bit of a different relationship that you spend more time trying to cultivate. It's important to build trust. The ED is probably the biggest place where this is important. When you're talking to ED physicians in the middle of the night, and these are docs that you see every day, they're in the lunchroom with you, you want to make sure that they know that what you say is something they can trust. If it's 2 o'clock in the morning and there's a fracture that you feel comfortable that the ED doc can reduce, if they trust you that you're going to back them up, that you're going to tell them only the appropriate advice, then they're going to be much more willing to do that reduction and then give you a call once you check the x-rays. But that takes a little bit of time. So that first year or two, it's important that you show your face in the emergency department, make sure people know that you're competent and that you're going to make good decisions even in the middle of the night. And this is a big one. I think both Sarah and Nicole have touched on this one. And I thought this was probably the hardest part of starting practice was, how do you deal with complications? And that first question there, can you truly be prepared? And to be honest, I'm not sure you can be truly prepared for the emotional roller coaster that complications can present. I do think that being prepared for that, just understanding that those emotions are headed your way, are important. There are certainly going to be some sleepless nights. And I can remember, like yesterday, my first few months of practice, nights where I'd be up at 1 o'clock or 2 o'clock in the morning, wondering how am I going to talk to a family the next morning. And that was particularly challenging. I think your job now during the residency is to make sure that you are looking to learn from people's examples, not just by words. So if you see a patient that comes into clinic to see an attending, and the attending says this is going to be a complicated patient or one that didn't have a good outcome, those are probably the rooms that you need to really make an effort to go into and say, listen, I'd really love to see how you handle this. How do you talk to this family? If there's one thing I could change, if I could go back to my PGY 4 and 5 year, that's probably what it would be, making a more concerted effort to go into the room with these complicated patients instead of going to the next room to keep the clinic flowing. And I can tell you in the fellowship, and as you progress through your orthopedic career, at each level, you seem to become a little bit less concerned about the operating room and more concerned about clinic. And I remember when I was at HSS for fellowship, there were 8 fellows total for total joints. And almost all of us were lobbying the fellowship director to let us get into clinic more because we were starting to get pretty concerned about how do you have these tough conversations. And it's difficult when you have a parent of a child who's upset, or you have a spouse that's upset, or even you have a patient themselves who had a really high expectation for surgery and they're very disappointed. It can be really difficult to know how to handle those scenarios, especially if you're already running late in clinic, but you have to take time to show empathy. So reach out to your attendings if you see those patients come in. Make sure that you make an effort. M&M is going to give you some formal exposure, but I think the more difficult conversations take place in the examination room. So lastly, in a few years, all of you guys will be ready to get to work. there is no doubt that you're going to have a lot to learn in those first couple of years. You will, however, be completely prepared. Like I said, I did start off in a level 1 trauma center, and it was very nerve-wracking. But within the first few weeks, you start to realize that you know the things that you need to know. And if you don't, you know the resources that you need to know to find them out. I remember my last night of call before I moved back to Charlotte. I was kind of hoping for an easy night. And of course, I got a call at 2 o'clock in the morning about a APC3 pelvis with a hemodynamically unstable patient, and the fracture was open into the vagina. So at 2:30 in the morning, I was putting on a pelvic X-fix while the OBGYNs and general surgeons were standing behind me in the operating room. And, you know, a few hours later, we were hopping on the moving truck. I had to chuckle at that, you know, that night, because I said, when was the last time I had to put on a pelvic X-fix? But when it came time to take care of that patient, I felt prepared and I was very comfortable, and things went just the way they're supposed to. So keep those things in mind. Take great notes, like Nicole and Sarah mentioned. I refer to my notes all the time. So take good notes. Every little detail matters, and those are the things that are going to stress you the most. But overall, just recognize that you're going to be prepared. Thank you.
Great. Thanks, Dr. Bates. Really appreciate it. Yeah, the complication piece has come up a number of times. I think that's something that everybody, you know, obviously has to deal with. And that may come up a little bit more later on with the little Q&A at the end. So, but I appreciate those pearls. So, Dr. O'Day, if you want to load up your talk. So Dr. O'Day is a 2018 graduate of CMC. She also did the research fellowship. She went on to HSS to do a sports and shoulder surgery fellowship. She is currently in practice in Greenville, South Carolina, at Prisma Health Upstate. She also has gotten very, very quickly involved with a lot of research. I told her the other night, actually, I think it was last week, I said, you have now, quote, made it, as you are on as many Zoom calls as all of the rest of us. So she has been very instrumental in starting a multi-center study that we will actually be a part of, called the Profiling of Orthopedic Surgery Trainees, that I think will provide a lot of data to our residents that will help them through residency and beyond. So Dr. O'Day, I'll turn things over to you to talk about research after residency. You're muted. Thanks.
You think with all the Zoom calls, I would remember how to unmute at this point, but thank you all. I'm excited to be back to give this talk and to see everyone again. So I'm just going to roll ahead pretty quickly. And we'll talk about some of these general tips for early in practice getting involved in research. So the first thing I would say is decide first what kind of research practice you want to have. Get familiar with your resources. Consider being a journal reviewer for your subspecialties. Collect PROs from day one. And also start small with clean studies or collaborate with those with more experience. So before you start, so decide what kind of research practice you want to have. And some of those things that you have to consider involve being, do you want to have protected research time? These are questions that you probably should be considering when you're looking for your job. And they're important questions to talk to your potential employers. Do you want it to be a half day? Do you want it to be a full day? Do you want it to be no protected time at all? I would say it's easier to ask for it now rather than later. And that was echoed by several of my mentors coming out of fellowship. And remember that regardless whether or not you have a research time, nights and weekends are still going to be an integral part of participating in research. The other question is, do you want to participate in basic clinical or translational research? Do you want to participate in resident training research? Is research productivity part of your department promotion? Because that would definitely factor into what resources you need. Can you develop collaborations with other institutions, whether locally with local universities or with other healthcare systems that are nearby? And I think that's particularly helpful for participating in clinical research early in practice. And then get familiar with your resources. What does your research department have? Do you have a dedicated research coordinator, a PhD or a master's level researcher? Do you have research assistants that are available that are dedicated to research tasks? What's your statistical support? As all of this is going to help guide you in terms of how much do you have to do on your own and how much support do you have to get research off the ground and to publication. Another big question is, how timely is your IRB? Is it something that things go through pretty quickly in a timely manner? As you know, in some settings at HSS, getting through the IRB sometimes can take a whole year. And believe me, I have experience with that. Others can be pretty short. So understanding the dynamics of that is important. What are your local funding sources or other sources of funding for research? And also, what data collection and protection of data is available? Are there established patient-reported outcome collection platforms, such as through Epic? Other people can use Promise. There's a SOS, which is the surgical outcomes, which is through Arthrex. And then there's some ones that you have to pay through OBIRD. And then also REDCap offers the opportunity for you to personally collect data without being specific to a single entity. And then who's going to perform your data entry? Do you have collaboration with radiology in terms of formal reviews of radiographic assessments? Do you have collaborations with physical therapists? All of this will guide what kind of data that you can collect in your clinical practice. Another option I would say consider is become a journal reviewer. Most societies, if they are starting to have candidate membership options, seek members to be volunteers as reviewers. I'm a candidate member of ASCS, and that's one of the criteria as they ask to be a journal reviewer. It also provides you leverage for when you're trying to become a full fellow member of your different societies to be a journal reviewer for their dedicated journal. But also as a researcher, it allows you to critically think and review other studies within your specialty. And what I normally do is after I review a paper, I go back and I read the other reviewers' comments. And I try and see, did I align with what the other reviewer thought? Was I more critical than them? Was I less critical than them? And then I re-review that paper through their lens, because I think it helps provide insight both into how you can critically think about different papers, but also how to develop your own future studies in your subspecialty. And then this is where I think, particularly in early in practice, this is probably the most important aspect, and that's collecting patient-reported outcomes. You should try and make this part of your patient intake and your routine follow-up, integrated into your electronic health record if possible. Sometimes it's only through paper, but oftentimes you can do it through the computer or a tablet when possible. And use intervals that are consistent with current literature. The most important being baseline, baseline, baseline. Certainly we know garbage in, garbage out. If you don't have baseline data on your patients, then there's really not much that you can compare to in terms of short-term, intermediate-term, or long-term follow-up periods. The other thing I would say is with COVID, one of the things that actually has been a benefit has been telemedicine. I've actually also started integrating this for patients who are now in surveillance follow-up, is using telemedicine platforms such as video or even telephone to collect PROs, range of motion, clinical measurements. And that's something that I'm certainly going to continue forward. The other thing is include radiographic studies at baseline and also at appropriate follow-up intervals. And then the question is which PROs? I would say certainly get clinical measurements when possible and make that part of your exam. We have Epic here, and it offers several PROs, but additionally, I collect patient-reported outcomes that use clinical measurements within them, and they're integrated within my progress note. So in general, I would say pick a joint-specific PRO, one or two that are generally accepted by your subspecialty. You certainly need a general health or health-related quality of life scale, a pain scale, which oftentimes is actually already part of your joint-specific scales, but could simply just be a VAS A single question assessment, I think, will do in a pinch if you're limited in the number of assessments that you can collect. And then other ones to consider, if time permitting, is an activity-specific scale for return to play or return to work, as well as the satisfaction scale, though those can be relative. So here's an example. These are what I collect for my shoulder patients. I collect the ASCS scale, which is a patient questionnaire. And this is generally, when my patients are coming in with a new intake, they fill out these questionnaires. The constant is also one that I collect, though it's not as often used in the US. For me, as somebody who participates in shoulder surgery, it's pretty consistent with the international literature. And more importantly, it allows for a physician exam. So when I'm examining my patients, I measure their range of motion using the criteria that's within the constant score in terms of flexion and abduction, combine active external rotation and internal rotation. Eventually, my goal is to switch to the auto constant, which allows for patients to subjectively rate their ability to complete this, which hopefully with video options will make that easier as well. I also use the SANE score, and that's a question that you can use in any joint. Essentially, you just ask the patient, how would you rate your affected joint of interest today as a percentage of normal? And that's definitely picking up steam in a lot of different subspecialties. And that's actually the one that I really pay attention to when I'm seeing my patients in follow-up. Where are they relative to when I first saw them? Where are they post-op? How close to normal do they feel? And that helps actually enrich the conversation I have with them about where they're going. I also collect VR12 because that's consistent with what's collected by the rest of my practice. I used to collect PROMIS 10, which is a shorter scale. And at baseline, I collect the brief resilience scale, really now just for interest to see if there's any correlation with how patients react pre and post-operatively. And then for instability, I collect the WOC. So lastly, I'd say start small, collaborate with those with more experience, including mentors and colleagues for residency and fellowship, your current clinical partners. They can provide insight on what's feasible, both on a small level and a larger level. And I'd also say focus on straightforward projects with clean protocols. Long gone are the days when small retrospective studies with incomplete follow-up, limited exam or imaging are able to be published. They are becoming exceedingly hard to publish even in open access journals. Consider building a registry with your colleagues. It's challenging on the front end, but will pay dividends on the back end, as well as collecting the PROs that we talked about. And then the other thing is finish any outstanding residency or fellowship studies. I'm certainly still guilty of this. I'm still working through some manuscript revisions from fellowship, which tells me that research really never ends and they can take a long time to get through even some very good studies. And the last thing, be patient. Research takes time. And as long as you're dedicated and interested in something, it'll pay out in the end. And so I just wanted to give a special thanks to my past CMC collaborators with studies that I was involved in during my research year and then through residency. Thank you guys for all that you do, and I've learned so much from each and every one of you. All right, thank you.
Thanks, Dr. O'Day. Lots of great research pearls, I think, for kind of getting started in practice too, and even some of the negotiating prior to starting in practice. So maybe we'll have a few minutes to talk about that later. Our next speaker is one of our own faculty here. Dr. Loeffler completed his residency in 2011. He was the research fellow here the year prior to me entering the lab. He's been a friend and mentor, and I'm excited to have him with us this morning talking about innovation and continuing education after residency. Dr. Loeffler, take it away.
Thanks, Brian and Josh, for the opportunity to speak with you this morning. Are you able to see my slides there?
Yes.
Great. It's also been great to see the fellow CMC alumni and my former junior residents all growing up, including you, Dr. Scannell. I think they've given some great advice this morning, and you'll certainly see there's some common themes. So you asked me to speak about innovation, which is a new product, idea, or process, and I broke that down into what I think are the key elements for that. I think it starts with asking good questions. And usually that means, how can we do a better job taking care of our patients? A lot of times it means taking on the tough problems, how to restore function to a patient who's lost a limb or who's lost digits in the hand. And how can we incorporate and create new surgical strategies and technologies to achieve those goals? Number two is, I think it really takes setting time aside to get things done and to think. And so I've scheduled in academic time into my normal practice schedule, because time flies, especially when you get into a busy practice. And if you don't make the time, then you won't be able to make your new ideas come to fruition. Days become weeks and months and years very quickly. I think innovating means staying abreast of new techniques and technologies, figuring out what's worth adopting. And I think innovation really can mean bringing new techniques and technologies into a new practice or region. And a lot of times one innovation will lead to another. I've also found that for me personally, teaming up with like-minded colleagues has been extremely valuable and rewarding. Collaboration, whether it's in your same specialty or even another specialty, really allows you to propel your ideas and the work that you can get done. So if you can find colleagues who have the same goals in their sights, then you can accomplish some really great things. So for example, Joe and I have recently collaborated on doing osseointegration cases, not only to help patients with their mobility, for those that have difficulty with fitting a traditional prosthesis with the OI implant, but also managing the complex nerve problems that a lot of these patients are plagued with. Of course, Glenn and I have done a ton of work together in collaboration and innovation in my entire career that I've been here. And I think we both would agree there's no way we could have accomplished what we have as individuals as much as we have as partners. You push each other, you bounce ideas off one another, you can continue to carry the torch when someone else is bogged down on doing the things that they're doing their normal day-to-day, and allows you to just keep moving forward. And then a lot of the work that we've done with prosthetics, it's meant going outside of orthopedics even and engaging with prosthetists to tell them what our ideas are and how we can use their techniques and their skills and technologies to make things happen for our patients. So when you take a patient who has lost multiple fingers into a hand and say, how can you give them back the best function they can get with individual digital control of those fingers? And you draw it up on the back of a napkin, and then you take it to the lab and you see how it can be done, and then you get a prototype, and then 5 years later you can see a patient with unbelievable individual control on a myoelectric prosthetic, something that just absolutely was not possible previously, and something that I never would have had a dream that I would have had any interest in. But it was seeing a difficult patient, trying to figure out what could be done for him, seeing what technology's out there, making some new ideas, and making things happen. So as Sarah said, really, I think innovation too, it really requires you getting comfortable with being uncomfortable. And you'll never learn or see or do everything in your residency and training. So during your training, you really need to learn how to think, how to make decisions, and how to operate, so that you can carry all those skills into your practice, because you're going to continue to think and make decisions and do new things surgically. If you don't challenge yourself, you'll lose your edge. And that does not mean being a cowboy or a cowgirl. You have to know your limits. But at the same time, if you just do the same thing for your entire career, things will get fairly stale. So as you heard, I think in residency, it's very important to develop systems for note-taking, figure out a schedule for reviewing journals, looking things up as they come along. But really keeping those habits up in practice as we move on into the continuing education after residency portion of my talk. And as Gabby said, I think it's very important to be a reviewer. I'm a reviewer for Shoulder and Elbow and Journal of Hand Surgery. I was a section editor for the Hand Society's online video library called Handy for 5 years. And that's really how I've stayed on top of things. I also have said yes to basically every invitation to present at a meeting, and something like the Hand Society last week where I had 5 talks to give, You learn a lot by putting those talks together and also by being in those sessions and listening to other presentations. You make friends and colleagues across the country and share experiences not yet there in the literature. And then finally, if you can be part of a teaching faculty, it helps you to kind of keep a step ahead of those that you're teaching. So that's what I wanted to share about innovation and continuing education after residency. And one final thought that I want to share with you all is this concept of balance, which really was lost on me in residency and early on in my career. But I now feel this is absolutely crucial for long-term success and happiness. I realize that our careers are a marathon and not a sprint. And for me, the time with my family and my friends and having goals outside of medicine have really made my life more fulfilling. And my career success would be nowhere near as meaningful without it. Thank you.
Awesome. Thanks, Dr. Loeffler. I enjoyed being your junior resident as well. So I appreciate all the pearls today, as well as over the many, many years. So we'll have you stop sharing your screen. And then if everybody, if you'd like to participate in the Q&A, turn on your video so that we can see you all. I'm sure a few questions have kind of come across the chat. You know, again, I can't thank everybody enough for joining us. This talk's outstanding today. So many pearls that I think we could discuss if we had time. You know, one of our junior residents had asked about, you know, what types of things excited you? Are they the same types of things that still excite you? And I think I'll flip that in saying, what things in residency kind of made you nervous? And are some of those still the same things that you get nervous about in practice? Dr. Haynes or Dr. Pierre, any thoughts on that?
I think some of them are similar. I think some of them are different. I kind of decided I really liked doing bigger cases, more maximally invasive surgery like Dr. Pat and Dr. Niesel taught us. So I really like doing big cases. I like the thought process. I like the interest that it brings. I don't think it's necessarily subspecialty specific, but I think you kind of decide what environment you work in, what facets of the career are you interested in residency, and then, you know, what types of cases do you like?
When I left residency, I wasn't 100% sure if I wanted to do hand or trauma, and it took me about 4 months of practice to figure that out. And I think that was because, you know, as soon as I started doing the trauma cases, I realized that that's the bread and butter surgery that I like, and doing carpal tunnels was not really doing it for me. But that being the case, my practice now is probably of the trauma I do, probably about 50 or 60% of it is upper extremity. And the other thing that I feel like my really strong hand foundation at CMC helped me with, and North Carolina helped me with, is that I do a lot of amputee care and like my cases today are all TMR cases. So I do a lot of nerve surgery, I do a lot of limb optimization, and that's something that I feel really comfortable with based on my training and that I really enjoy. And so the skills that I got during training are the things that I'm using now in a different way than I ever imagined, but something that I find really fulfilling and really exciting. So it's taken me to a new, interesting place in my career. As far as what to be nervous about, you know, in some ways I didn't even know what we should be nervous about. And I think the hardest thing now is that I find is, you know, I'm a big planner, so I plan a lot for my surgeries, and that kind of helps with a lot of the anxiety. You know, there's Billie Jean King said that that pressure is, you know, having like the pressure to perform is actually a privilege because it shows that you have people that are counting on you. And so I take that very seriously. And talking to patients about complications is hard, and that kind of makes you nervous. But once you've gone through it and you have good relationships with your patients, then again, it's a time for you to grow, and you can often kind of end up in a very positive place.
I would echo everything.
Yeah, go ahead, Dr. Ade.
I'll just add one quick comment. I'll echo what Nicole and Sarah said, that in particular, some of my interests stayed the same in residency. You know, I always loved shoulder arthroplasty. I still do. That's probably where I see the most complex patients that I have. But an area that I didn't realize I was as interested in is cartilage restoration of the knee. And that was from experiences I had in fellowship. What I would say is focus on the things that keep you mentally stimulated. So, complex cases in shoulder arthroplasty, I find interesting. I don't mind thinking about them or seeing, difficult patients. But the other thing I would add is what I learned in practice so far is those complex patients also have complex medical issues that you have to manage and you have to be able to prepare for. And even in the last year, I've evolved in how I obtain clearance and optimization of my patients, my interactions with their medical providers. I have an interest in instability, and inherently that means I have to have conversations with people's neurologists if I have a patient who has seizure-related instability. So those are things that you don't really think about as much in residency, but you have to be prepared to be a doctor and be prepared to see the complex side of what's going on with patients beyond just the surgery itself.
Great. Happy to open the floor up to any of the residents. Dr. Seacrest had put a question in the chat box. Eric, if you want to.
Yeah, absolutely. So one of the things that several of you guys hit on there was this notion of, being willing to say yes to everything when we're starting off. And it's something that was hit on during our visiting professor last year as well. And he phrased it as, you should never say no to anything for the first 5 years of practice. But that seems like a really dangerous game to play, and seems like a way to end up stretching yourself really thin across things that you aren't interested in or, don't actually want to be involved with. How have you guys struck that balance when you are starting out?
Brian, you had mentioned a little bit at the end there, especially about balance. Do you want to comment?
Yeah, I think there's a million things that you can get involved in, but typically when somebody is asking you to participate in something, if it's writing an article or a journal, a chapter or speaking in a meeting, that's because they see something in you. And so I think you want to be the person who's known of as being someone who's reliable, who's willing to do the work and give the presentation. And it's, I may be asked to give a talk on something that it's not a topic that I'm passionate about. But early in career, I'm going to show everybody who's in the audience and who's on that panel and who asked me that I'm going to do a good job if I'm asked to give a talk, for example. Or if I'm asked to write a chapter about something, it's going to be a really good chapter kind of thing. So I think as your plate gets full, then you have to start saying, okay, these are the things I'm most interested in. But you want to people want to feel you out early on. Is this someone that I can rely on who's going to be a contributor? Or is this somebody who's going to just kind of fade away? Because it's very rare to just kind of not make any contributions in your first few years of practice and then suddenly be a contributor. So I think it's a way to just let everybody know that you are willing to be a contributor and do a good job when you're called upon.
The other thing I will just add into that is that you don't know early in your career where these relationships will lead you. And so some of the, like Dr. Bates mentioned, some of the relationships you make around the hospital that seem at first like, you're just chatting with a medicine doctor or this or that, you don't know where that will leave you in terms of your career or even your ability to care well for patients. So in the beginning, I think it's important to really show that you're a team player and willing to participate, whether it's in your own hospital or on a national or international stage. And as I'm in the middle of my third year, I'm starting to diary some of these committees and things that I don't like, identify a junior partner who you can say, hey, I got this thing for you. So some of that can happen over time as well. But in the beginning, I'd say take advantage of all these opportunities because it's just a way to get yourself going.
I'd like to comment on something that was raised by Michael and I believe Sarah as well, which is the concept of managing complications. And some of y'all don't have enough gray hair to really have been through this a number of rounds yet, but I see Steve on and some others. But this, if you care about your patients, this is the worst thing that happens to you. It's worse than something happening to you. And no matter how good you are or how long you've been at it, it's going to be something that we live with. And I learned from John Bergfeld, who was one of my mentors, that you got to get back on the horse. So it's just one of the aspects of mental toughness that we all have to deal with. And then obviously learning from your mistakes and making sure it doesn't happen again if it's on you. And a lot of the times it won't be on you. Some things happen in biological systems that aren't your fault. And I can tell you that all of my great mentors, both at special surgery and at Duke, were sued at some point in their careers too. And these aren't things that we talk about, but they have a lot to do with physician welfare and with your own sanity in a lot of ways. So don't hide from complications, get help, get your senior partners to help you with that. And just expect that it's going to be a matter of course. The best people you know have been through it. So don't run from it.
I think being known for how you handle your complications is far more important than being known for your complications. So, just learning how to adapt to that and deal with it is important.
Michael, you had talked about complications and sort of in regards to, something that maybe you would have done differently in residency, of kind of taking the time to, listen to the attendings and those patient encounters of dealing and discussing some of those complications with patients. Are there other things that you or any of the other speakers this morning would have done differently with residency? I thought that was a great example of sort of that pearl of get involved with those patients and those patient interactions. But anything different that you in practice now has said, you know what, I wish I spent a little bit more time with X, Y, or Z?
From a clinical perspective, I really don't think I have any regrets there. I think sometimes if you know what you're going to do early on in your residency in terms of fellowship desires, you tend to get a little bit pigeonholed in reading only papers from, let's say, hand surgery or spine surgery. I was fortunate in some ways that I didn't realize I was going to do joints until probably the middle or end of my PGY3 year. And what that did was it allowed me to have an interest in so many other things early on. So I hung out with the hand docs and loved hand for a while. I loved spine for a while. And by having so many interests, I think it really made me pay attention to all the different services. And that serves you well once you actually get out into practice. And in terms of regrets, I still would say the biggest thing would be spending more time with those difficult patient conversations. Because even 5 years later, and I can't believe I'm in my 5th year of practice already, that is by far the most difficult thing that I think I do. And I remember my wife, Tiffany, who's an OBGYN, who's a couple years behind me, when she saw me going through those first several months and dealing with complications, and it's Christmas Eve and I'm sitting in a nursing home to visit a patient that had a complication, I think she really started to realize just how taxing these things can be on you as an individual. You bring these things home with you, and they can be taxing on your entire family. So that's probably the single biggest thing that I think myself and other trainees, especially in my fellowship, we all had that same impression. And just to touch back on that previous question about work-life balance, I agree with everything that was said by Brian. One thing that I think goes a long way is communicating with your spouse, your partner about all these engagements. It's nice and it's great that you stay engaged, but I think you have to make sure that you're taking care of your home life as well. So that means, when I agreed to do this, talking to my wife and saying, hey, I'm going to be unavailable to help with the kids Thursday morning, so you're going to be on your own, and making sure that you're communicating well. So if you hear some kids screaming in the background, it's because she's doing it by herself this morning.
Great. I think we're getting close. We're a little bit over time, but obviously I wanted to make sure that everything was answered. I think Dr. Haynes needs to run off to work, and certainly if anybody else needs to jump off to get to patient care, I certainly understand. Any other final questions or anything that the residents.
I'll add one more thing in terms of one thing I've learned in practice that I wish I'd done in residency. Think thoughtfully about how you explain orthopedic pathology to your patients. When I started practice, I basically give all of my patients refrigerator art. So a diagram of a shoulder or a knee that I write on and tell them what the diagnosis is, what the plan is, and when I'm going to see them next. And for me, part of it is allows me to kind of explain to them in depth what is going on and what I think is going on, and provides a little bit more transparency for them. But I also understand that patients can't digest a lot of information in one sitting. And it allows us to kind of have something that we can circle back, or they can show to a family member when they get home and says, this is what the doctor told me. I have this kind of rotator cuff tear, or I have a torn ACL, and this is what this means, and this is what the next step is. That's one area that I think I've found a big clinical benefit, and I would encourage other people doing, because you don't know the level of healthcare literacy of your patient population. In where I am in South Carolina, it's quite low. So I understand that there's a responsibility for me to explain something to a patient that they probably never heard before. So those are my last thoughts.
Great, thanks, Dr. O'Day. Dr. Pat, Dr. Mormon, any other final comments?
No, that was incredible. Thank you all for joining us this morning, and Dr. Scannell for moderating. That was a really fun way to spend the day, the morning, to get started. Kind of reinvigorates you, seeing all of these faces and sort of seeing where everybody is now. And Loeffler, you are my junior, so don't forget about that.
Never.
Great session. Thanks, everybody.
Thanks, T.
Thank you all for joining us this morning. Really appreciate it. It's been great seeing y'all's faces, and look forward to seeing you hopefully in person at meetings in the future. Have a great day.
Brian.